Thank you for inviting me. I'm going to be talking about a topic that's very important and near and dear to my heart. So we'll be talking about early onset colorectal cancer. Our objectives today include describing the epidemiology, the risk factors as far as we know, and screening. And we'll review the differences, clinical differences, and some of the unique issues that we deal with when patients have early onset colorectal cancer, and then interspersed throughout talking about recent early onset clinical CRC research and what are our future directions. So epidemiology. Overall, we're doing a great job with colorectal cancer. It is decreasing in incidence. This is likely due to effective screening with colonoscopies, other screening modalities, which I'll talk about. And in this slide over here, we see that the ages are 55 and older. So in that population, we're doing a good job. But unfortunately, it is increasing in the younger population. So in this slide, we have patients 20 to 49 years old. And depending on the definition that you see, we typically refer to young onset colon cancer being patients who are younger than 50 years old. And unfortunately, since the 80s, we are seeing this very alarming increase in incidence of young colorectal cancer. And when we look at colorectal cancer incidence rates by birth cohort, it really started in the group of patients that were born in the 1960s. And then just some facts about colorectal cancer in general. In 2021, we did see 150,000 new cases, and 45,000 of them are rectal cancers. Currently, it's the second leading cause of cancer death for men and women combined. When we look at these respective charts over here, for colon cancer on your left, you're seeing that we are seeing an increase in the younger population. So that blue line is a 20 to 34-year-old patient population, and it's increased significantly, about 90%. And then we go to rectal cancer, we're seeing even more of a market increase, 124% increase. And that is typically what we see in the clinic. Many of my young patients are presenting with left-sided colon cancer, left-sided colon and rectal cancers. In that young population, the 0 to 49-year-old range, almost 18,000 new cases in 2020. When we look at geographic incidence of this young onset colon cancer in the US, so on the left you have the numbers from 2001 to 2005, and overall the incidence was on the lower side, although you are seeing some trends in the southern states. And then on the right, from 2011 to 2015, you're really seeing this alarming trend where there are some states that are in the red. There's a clear uptick, and unfortunately, I'm a little bit wary about what the newer graphs, in the 2020s will see. And then when we look globally, the countries that are documenting an increase in early onset CRC is really the developed countries. So North America, Europe, Australia. And so there are some common risk factors that these developed countries are sharing, unfortunately. So the take-home points from what I present so far. So increased incidence seen in the developed world. We also are seeing a marked increase in the non-Hispanic white patient population. Early onset CRC accounts for 10% of all new diagnoses, and early onset CRC-related mortality is also increasing steadily in contrast to the patients who are older with this diagnosis. And as a result of this, the median age of diagnosis initially was 72 years old, has now dropped to 66 years old. And unfortunately, in the next 10 years, 25% of new diagnoses of rectal cancers will occur in patients younger than 50 years of age, and 10% of colon cancers. So what are risk factors? And this is going to be a presentation of some data. Overall, we don't really know, especially in the sporadic colorectal cancer diagnoses. So let's talk about inherited factors, because that's almost the easier one to talk about. So inherited factors, 30% of early onset colorectal cancer have a first-degree relative with this cancer. So even if they don't have a clear mutation associated with their cancer, it's important to identify these patients, especially if they have a strong family history of colorectal cancer. 3 to 5% prevalence of hereditary colorectal cancers that we should be able to identify. Lynch syndrome, which is a deficiency in the mismatch repair proteins, is most common. And we know that 25% of early onset CRC has a hereditary colorectal cancer syndrome. So looking at these images that we have. So on the left is the early onset colorectal cancer. So in that piece of the pie, about 20% of patients have some kind of clear inherited germline mutation that can be identified. But the rest of the pie is this sporadic case where we're not really sure why they got this cancer. And this is in contrast to the right pie, where in older patients, the incidence of some kind of genetic inherited mutation is only about 10 to 15%. So as a result of this, the NCCN does recommend that genetic risk counseling and evaluation should occur for all patients under the age of 50 who have a new diagnosis of colorectal cancer. And in terms of what to test for, it should at minimum include the mismatch repair genes and then some other implicated genetic alterations, which I've listed here. And what's nice about referring a patient to genetic testing is that they can counsel the patient and let them know that if they test positive, what are the implications for their first-degree family members, especially if they're on the younger end, how to approach that very delicate situation. So going into what is a hot topic of research, what are the risk factors for sporadic colorectal cancer, especially in the young patient population? So like I mentioned before, we are seeing that increased incidence in the developed world. In the young population, the exposures are probably happening early on in life because they're developing this cancer quite early on. So we know that most likely diet is involved, and I'll go into that. The microbiome and related antibiotic use. Also know that there is some association with lack of exercise, possibly some perinatal exposures, and the more common risk factors like smoking and obesity. So when we go to diet, there's obviously been some change in our diet, especially the Western diet. And we think that the diet has significantly changed over the last 50 years. We are, taking in more processed and red meats, which we know has associations with higher risk of CRC. We tend to like our refined grains. So refined grains have a higher risk of CRC. Our whole grains, the bulgur, like the quinoa, that seems to have a protective effect. And then processed sugars, it's everywhere. The sugar-sweetened beverages in particular, that all has associations with higher risk of CRC. So these are all the fun things that we love to eat that are causing issues in our current diet. So this is a nice meta-analysis looking at the dose response of foods and beverages and how that plays in with the risk of CRC. So the boxes on the right have an increased incidence association with CRC, and the boxes to the left of that line have a protective effect. So like I mentioned, whole grain seems to have a protective effect. Things that probably are increasing our risk for CRC include red and processed meats, and some associations with alcohol too. And then fish, dairy, milk, cheese may have a bit of a protective effect. Fortunately, we're not seeing any issues with coffee, so that should be good news for everyone. And then when we look at the association of obesity with early onset CRC, this was based on data from the Nurses' Health Study, which looked at females 25 to 40 years of age who had early onset colorectal cancer. And we see that, with very high BMIs, 30 and higher, we are unfortunately seeing a higher risk of CRC. So, we should really counsel our patients on trying to reduce their weight in any way possible. And then similarly, when we see changes in weight, so from the ages of when they're 18 to when we first meet them, if there's been a significant change of weight, a BMI of greater than 23, that is also associated with a higher risk of CRC too. And then in men, we're also seeing some associations as well for that last line, the overweight category. If they remain overweight starting at age 7 to early adulthood, that has the highest risk of CRC. And unfortunately, we are seeing that our pediatric populations are struggling with obesity. And I know that the pediatric associations have put some very hard guidelines recently to try to reverse this trend in our youngest patients. Very intriguingly, what is the role of antibiotics here? We know that antibiotic use has increased significantly, and there's been thought that we know that antibiotic use definitely changes our microbiome. This was a study in the UK looking at patients with CRC, and this was kind of all ages too. You know, interestingly, we found that the risk of colon cancer, not necessarily rectal cancer, but colon cancer increased after antibiotic use in a dose-dependent fashion. And it happened with certain antibiotics, not all antibiotics. So it looks like penicillins are the culprit here, but not cephalosporins, macrolides, or Bactrim. And interestingly, when patients used prolonged antibiotic use, especially tetracyclines, it appeared a protective against rectal cancer. So knowing that our younger patients are having a higher incidence of rectal cancer, you know, it seems like antibiotics alone are not the causative agent for this increase in early onset CRC. We are seeing this association occur about 10 years after the use of antibiotic exposure. This is just like a nice cartoon showing possible implications of what the microbiome is doing to cause this increase of young onset CRC. So on the upper left, you have antibiotics, high-fat diets, diet-induced obesity, also contributing to this alteration in the gut microbiome, and all this may be contributing to early onset CRC. So there's a lot of hand-waving here. We still need to nail down the exact combination of risk factors that are producing this issue. And then this is a nice cartoon from a recent opinion piece in the New England Journal of Medicine by Dr. Sunnie Kim. So when we look at exposure, so we do think that obviously, at infancy, there are some inherited genetic alterations, like I mentioned, about 25% of early onset colorectal cancer can be explained by that. And then there is some sex differences as well. And then as we go into childhood, that lifestyle influence is important. So diet, the processed meats, the sugary beverages, some of the physical inactivity that we're unfortunately seeing, and then perhaps the antibiotic use. And then as we go into adolescence, all these dietary behaviors may be resulting in metabolic syndrome and diabetes. And then as we get older, obviously the smoking and alcohol use doesn't help. And all this may be contributing to this increased incidence. So the take-home point from this section is really there is no probably one cause of early onset CRC, which makes this discussion more difficult to have. This is some kind of generational environmental exposure that we're getting. It's likely a combination of numerous factors, and we are very intent on trying to uncover these risk factors. So until then, what is our best tool? Screening, obviously. So these are a number of societies that have put out recommendations about what we need to do with this alarming trend. Some general CRC screening facts: only about 60% of patients in the US undergo CRC screening, although this is a clear, validated, and effective screening strategy. And what are our barriers? So there's that lack of knowledge, understanding that screening helps. There's also, unfortunately, in different parts of the country, lack of access to a healthcare provider who can make these recommendations and who can perform these tests. And there's just overall reluctance. No one wants to talk about the area. The prep doesn't sound, that appealing. The actual procedure itself is not appealing. You have to take time off of work to do these things. It takes about 2 to 3 days to get a colonoscopy done. And of course, the rate of screening is lower in uninsured patients, low income, and then racial and ethnic minorities. So the American Cancer does recommend that people of average risk CRC start regular screening at age 45. For patients who are 76 to 85, the decision to do screening should be based on the patient's preferences, their life expectancy, overall health, and then their prior screening history. And then people over 85 generally should not be recommended to get colorectal cancer screening. In terms of what screening tests are available. So there are stool-based tests. There is the fecal immunochemical test, FIT, which essentially detects blood. And then there's also the guaiac-based fecal occult blood test. So the FIT and the FOBT both test blood in the stool. And if that is chosen, that should be done on a yearly basis. And then there's a stool DNA test that can be done. We recommend that every 3 years. And then, of course, there's more of the visual structural exams of the colon and rectum. The colonoscopy is the gold standard. Currently, they say every 10 years. Maybe there's some controversy in the field about that, but the recommendation is every 10 years. CT colonography or virtual colonoscopy is every 5 years, and a flexible sigmoidoscopy is every 5 years. And that's knowing that most of our younger patients are getting cancers in the left side of the colon. The flexible sigmoidoscopy may be able to detect most of those cancers. The United States Preventative Service Task Force guidelines also put out recommendations. They also make a recommendation in the B grade that adults 45 to 49 years old should get screened for colorectal cancer. So it's not their strongest recommendation, but it is certainly a recommendation that they have put out. So the take-home point here is that really 45 is a new 50, or if there's a strong family history, 10 years before the youngest case in the immediate family. And then patients 76 to 85, consider the patient's health, how robust they are, what are their goals in life, what are their other comorbid conditions. And then colonoscopy truly is a gold standard because even though if there may not be cancer, you may be catching those precancerous polyps that could later on become cancer, and you just want to be able to take those out. And then, there are some molecular investigations about are there any tumor molecular differences between older and younger patients? So yes, there are some differences. The orange bars are the patients who have older onset colorectal cancer, and the blue bars are the patients who have younger onset colorectal cancer. And so we, in the top figure, that's the microsatellite stable. That's what we're seeing mostly, and the bottom is the MSI high cohort. So in the upper figure, we're seeing more P53 mutations, less so APC, KRAS, or PIK3CA. And then in the MSI cohort, interestingly, in the younger patients, we're seeing a lot more APC mutations, KRAS mutations, PIK3CA, and far less BRAF mutations. And then this was a germline mutation analysis done at Memorial Sloan Kettering, and we do see that in the younger patients, which is represented by the red and orange bars, there is a very high incidence of inherited germline mutations. In their study, it was as high as 23%. Also, trying bring home that message that these young patients really need to get that genetic testing or be referred to a genetic counselor. So what are the outcomes for early onset colorectal cancer? It's not really clear. Do younger patients have a better survival? We would like to think that younger patients, because they're healthier, they can tolerate more chemo, tolerate multi-agent chemo better. And we think that for earlier stages, perhaps younger patients fare better in some studies. But when they have later stages of disease, younger patients fare about the same or worse than older patients. And we think the reason for that is that younger patients seem to present with more advanced disease. There's a lot more delay in their diagnosis. There are a lot of practitioners out there who feel that young patients cannot get colorectal cancer, that their bleeding is probably due to hemorrhoids. So their diagnosis gets delayed like 6 to 9 months. And then unfortunately, the younger patients also seem to have more aggressive tumor features, more poorly differentiated pathology. And then, what are the special considerations for patients with early onset CRC? I have a number of these patients in my clinic, and these are patients in their 30s and 40s who are at the peak of their earning potential, have young children. I mean, it's truly tragic. They have to take time off of work. Who's going to take care of these young patients? It's truly devastating. And we know that being more aggressive, having a multidisciplinary approach may be able to improve their survival. So in our institution, patients with even stage 4 CRC, we get all the groups involved. So surgery, medical oncologists like myself, radiation oncologists, interventional radiology, to try to come up with plans for them, because we know that resecting metastatic lesions in a certain group of patients can improve survival. So don't think that just because it's stage 4 that we can't try to get more years in them. And then of course, like I mentioned on the bottom, having genetics and social work involved is really important. And then oncofertility, some of these patients still want to have children, especially if there's probably going to be a surviving parent there. So referring them to fertility is also very important in a timely manner. And then, like I mentioned, other considerations, we know that there are delays in diagnosis in these patients. Patients seem to really like connecting with other patients who are dealing with similar issues. A doctor can tell them what this is going to look like, but they take it a lot more seriously if they're talking to other parents, other young people who are dealing with the same diagnosis. There are tons of financial and insurance concerns. I have one patient, a 41-year-old, who is a woman, and she's the primary, the breadwinner in the family. They have 2 young children, and she's out of a job right now getting disability. The husband is trying to take care of the children, so it's a huge burden on them. And then, of course, there's a lot of social and emotional issues. There's the physical changes to their body, like the hair loss. Some of these patients need to have ostomy bags. It's huge. The anxiety levels are obviously sky high in these younger populations. They're trying to understand how to break the news to their parents, to their children, and what to do about their dreams of their careers and schooling. All that kind of goes down the tubes, unfortunately, down the drain. And then, like I mentioned, fertility needs to be addressed too. So how do we optimize the care of patients with early onset CRC? This was a recent paper that was published, and it really starts at diagnosis, and it goes through cancer treatment, and even patients who survive this diagnosis, when they have early stage, stage 1 to 3 colorectal cancer, they still have tons of remaining issues and trauma from their experience. So obviously, you have this slide in your notes, so you can look into this. But there's so many factors that are involved in taking care of a patient in this age group. And then, like I alluded to before, there's an impact of financial toxicity of this early onset CRC. There's a lot of physical fatigue, emotional fatigue, and stress. They lose their earning potential. They deal with this financial toxicity, and that can cause a myriad of issues. Not just for themselves and their mental health, but also for the people that they're supposed to be taking care of. And that stress can lead to more poorer health outcomes. So in summary, early onset colorectal cancer is rising in incidence. This is a worldwide trend seen in developed countries. It is being driven by higher incidence of rectal cancer. There is no one risk factor, but we think that diet, possibly antibiotic use, alcohol, lack of exercise are risk factors, and patients under the age of 50 should be referred for genetic counseling to make sure that if there is an underlying genetic alteration, that be identified. For screening, 45 is a new 50. If there's a family history and you're younger than 45, please speak to your doctor about whether you should get earlier screening done. And then colonoscopy truly is a gold standard, but if you don't want to do that, there are other tests that we can do too. Just screening, any kind of screening is very important. And then young patients should have access to a multidisciplinary team if possible to address some of these unique issues in their age group. And the final message, of course, is that you are unfortunately never too young to be diagnosed with this disease. And I just wanted to mention this because it's always important to put a face to a name. So the woman here, she is actually being treated by my colleague. She was initially diagnosed with stage 3 colorectal cancer when she was 32 years old, unfortunately recurred in her lung. And then as she was going through a diagnosis, her husband actually got diagnosed with stage 4 rectal cancer, and I am taking care of him right now. And their son was 5 years old at diagnosis. He's now 6. And, can you imagine trying to balance just everything involved in taking care of a young child, trying to balance chemo visits, and he just is actually still in the hospital getting over surgery. He had just liver metastases, so we're trying to be very aggressive in him, but I don't know how you live like that, trying to imagine that your son will likely be orphaned at one point and just trying to live day by day. So it's awful. It's really awful. And they did give me permission to post it. I did talk to him earlier today, but it's tragic. And unfortunately, we're probably going to see more and more of these cases. And the consequences are enormous in our young patient population. So that's it. Feel free if you have any questions.
Thank you.
And I have a colorectal cancer expert in the back over here, so I'm sure he can answer some questions too. I know this is a passion of his as well.
Any final questions? Yeah.
Can you just explain the difference between MSS and MSI?
Oh, yes, of course. So we have proteins in our body that help with repairing DNA damage or DNA mismatch repair. There are 4 proteins that are typically associated with it. So when we lack any of these proteins, a DNA needs to be able to divide without error. And if that doesn't happen, then you produce these errors in mismatch repair. And then you produce what we call these microsatellite repeats. And that results in something called microsatellite instability. And for whatever reason, the immune system seems to be much more activated in these kind of tumors, so they end up being much more receptive to immunotherapy. Mm-hmm. Yes? Thank you.
So the stools test, which indicative of only the blood, by the time you find it positive, isn't that going to be too late?
I mean, you never know. I mean, it could be still early stage. So, the message is colonoscopy truly is the gold standard. But if the patient is super reluctant and you want to do the blood-based tests, I mean, something is better than nothing for sure. And it depends on your definition of too late. May they already have cancer, possibly. But if we find it earlier stage, then cure is possible. I mean, the DNA one is fraught with some issues too. I've had a number of patients with false positives. It causes a huge amount of stress for patients. There are some false negatives too. I think, again, if the patient is very reluctant to get a colonoscopy or some kind of direct visualization, I think a DNA-based test is fine. It's just that with the blood-based test, they need to do it on a yearly basis. They can't be doing it every 3 years. The DNA-based test can be done every 3 years.
Going back on to the MMR testing, is it something that pathologists do, right on, or does it have to have right-sided, left-sided? Because I've seen reports that don't have those, and we have to request them.
Yeah, it really should be done reflexively, and if you don't see it on the pathology report, I would definitely talk to the pathologist about having it done, because it has implications in stage 4 disease and earlier stage 2, namely the immunotherapy options.
In the preventative side, for the FIT, yearly FIT testing, would you recommend, if every year it was negative, would you recommend to do colonoscopy?
So they have a negative FIT test every year. Would you still push for the colonoscopy? I mean, I don't think it's a bad idea because, again, you may be on the colonoscopy, you're probably going to catch those early precancerous polyps that, if removed, will prevent colon cancer later on.
Thank you. Any other ones?
What is the efficacy rate of catching diagnosis between Cologuard and FIT tests? Is there any difference?
This is probably a better question for a gastroenterologist, so I don't have the exact numbers, but I'm happy to communicate with someone else once I look it up. Okay. Do you know?
65%.
There you go. Okay, 65%. So not that great.
Not great.
Yeah, it's not great.
Any others? Okay. Thank you.
Okay. Thank you very much.